All right, it's 1 o'clock, so we'll go ahead and get started. Good afternoon, everybody. My name is Aihan Jun, and I'm the president of the Southeast chapter of SCCM. Thank you for joining our meeting today. Before we go into Dr. Sigman's lecture, I would like to make a few announcements from the chapter. We start every meeting by stating the mission and vision of the chapter. The mission of the chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. The vision of the chapter is that all critically ill injured persons in the Southeast region will receive care from a present integrated team of a dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of the critical care in the region. May was the National Critical Care Awareness and Recognition Month. The Southeast chapter was excited to celebrate our ICU heroes by wearing blue and providing gifts for the chapter members who signed up. Thank you to everyone who participated, and we look forward to celebrating again next year. We have a bite-sized lecture coming up on July 10th at 12:30 p.m. Eastern Time on the topic of teaching critical care in Ukraine by guest speakers from Grady Health System. Please sign up, and also please reach out to us if you are interested in participating in our next bite-sized lecture series. We're also excited to host the FCSCS course on July 27th at Northside Hospital. This will be a hybrid of online and in-person skill session. Chapter members also can apply for reimbursement for a chance to take the course for free. Registration closes on July 13th and spots are first come, first served, so please register now. In August, we're excited to have our past national SCCM president, Dr. Nad Carty, speak to us about green ICU stability. Please look out for advertisement with a registration link. Please save the date for our sepsis awareness fundraiser event, Stamp Out Sepsis. This is the first year we're co-hosting a 5K run with a mission, Sepsis Awareness Georgia, to benefit Sepsis Alliance. This event will also take place. This event will take place on Saturday, October 5th at Lilburn City Park. Please look out for advertisement. Please follow us on our social media page. Today's lecture will also be available on our YouTube channel later on, so please follow our YouTube page. CE is provided for today's meeting. Please take a moment to scan or take a picture of the QR code on the slide. This QR code will also be available on the next slide and also at the end of the presentation. You will have 2 weeks to complete the survey to obtain CE. Now, we're excited to have Dr. Sigman speak to us on brain death evaluation and updated brain death guidelines. If you have any questions during the lecture, please utilize the chat box and we'll go over them at the end. And now I'd like to introduce you to our speaker for today's talk. Dr. Erika Sigman completed her Doctor of Medicine at Mercer University School of Medicine and completed her residency in neurology at Harvard Medical School, Beth Israel Deaconess Medical Center. She also did a fellowship in neurocritical care at Emory University School of Medicine and is a neurointensivist at Grady Memorial Hospital and Emory University Hospital. She is the co-chair of the Donor Advisory Council at Grady Memorial Hospital and is one of the leaders of the working group for Grady Brain Death Guideline Policy Revisions. And with that, I will hand it over to Dr. Sigman.
Thank you so much. All right. So thanks so much for having me come and speak on this topic today. I'm really excited to be here. So we're going to be going over the brain death determination guidelines that were updated at the end of last year. And really, we're just going to be talking about what's changed, what's new, and then some other pearls. I have no disclosures. So by the end of this talk, I hope that you'll be able to define updates in the brain death declaration guidelines and understand what's changed and what's new, understand the prerequisite criteria for brain death testing, so what needs to be fulfilled before you even move forward with brain death testing, and then you'll be able to evaluate a patient and determine if they meet brain death criteria or death by neurologic criteria. All right, so here are the guidelines that were published at the end of last year. It was very exciting because these were the first updates in over a decade. The other exciting things about this were that, there was a really panel of incredible experts in the field of brain death testing. And on top of that, you had representatives from SCCM, the College of Neurologic Surgeons, the American Academy of Pediatrics. And so it was really, a great group of people that came together to release these guidelines. Throughout the talk, if there was something newly discussed, new to the guidelines, I've denoted that with a yellow star and it says new. If there was an update or a change, then that's going to be an orange star and it'll say C. I'll also try to point that out as we go, but if you see those, you'll know what they mean. So why did we really need new guidelines? Well, previously the pediatric brain death guidelines and the adult brain death guidelines were separate entities. And so the group wanted to combine those for ease of use. And also, they really just were outdated. They hadn't been updated in over a decade. The other thing is, the guidelines wanted to address patients on ECMO, are there different considerations and things that we need to do to declare brain death in those patients? They wanted to specifically address patients with primary infanttorial brain injury, like devastating injuries of the brainstem. And they wanted to speak on the diagnosis of brain death in patients that are pregnant. So these are really evidence-informed guidelines. You can imagine that in the world of brain death testing, we really don't have randomized controlled trials. And so what they used was a modified Delphi format to reach consensus among these experts and try to come up with consensus for which these, guidelines were published. So some definitions before we get into the guidelines themselves and how to do brain death testing. So previously in the other guidelines, they would refer to they would call this brain death. So somebody who's had a catastrophic, irreversible injury to the whole brain, that patient would be diagnosed as having brain death or as declared brain death. They added just a slight additional wording change here where they said brain death or death by neurologic criteria. And the reason for that was just to be consistent with, we have death by cardiopulmonary criteria, and they just wanted to signal that brain death is it's not just the death of the brain, it's death of the whole patient. And so they wanted to be consistent with death by cardiopulmonary criteria, death by neurologic criteria, that is death of the patient. Just some other definitions. When I'm referring to child in these guidelines, I'm referring to a patient that's 37 weeks old by corrected gestational age and less than 18 years old. And just to note that patients that are less than 36 weeks old by corrected gestational age are not appropriate for brain death testing, as they're, the nerves are not always well formed by that time. So we would wait to do any kind of brain death testing until that patient had reached 37 weeks old by corrected gestational age. The other things that have changed with some of the definitions is instead of using the word irreversible whole brain injury or irreversible whole brain dysfunction, the guideline writers have chosen to use the word permanent just to indicate that functions have been lost and will not resume spontaneously, and there's not going to be medical interventions done to restore any of those brain functions. That wording is also more consistent with the the world's brain death project initiative. And so it just provides some consistency. But the definition of brain death has not changed. That in and of itself is still, catastrophic brain injury that is permanent, and there's no evidence of brain function. So the guidelines, there's 85 recommendations, but for all of our sanity, I'm not going to go into all of them, of course, just want to highlight a few important ones. But the overarching goals are that, this is a conservative set of guidelines, but it's practical, and that these are things we can implement and do in the ICU for patients. The point of them being conservative is that we want to decrease the risk of any kind of false positive. This is a diagnosis we have to get right 100% of the time. We have to think about public trust. We have to think about grief of families. And so this is not brain death is not a diagnosis you can make and get it wrong. So it's conservative for a reason. And then the other overarching guideline is that you always presume that the patient is not going to meet criteria, that the patient is in fact alive, and you're basically working through a checklist to disprove that fact. So the guidelines do start out by talking about what a qualified examiner is. Or should be. And essentially, this is going to be, in most places, an attending physician trained and competent in brain death or death by neurologic criteria exam, and somebody that has displayed competency in this exam. And the ways that you would show competency is different in different places. At both hospitals I work at, you have to take you basically have to be credentialed and take a short test in this. They do provide examples of the type of physicians that could do brain death testing. They give the examples of neurologists, intensivists, neurosurgeons, for example. They also comment on trainees and APPs, and I would just say that there's different local standards at hospitals, and so you have to refer to your local standards and laws, but there's certainly some places where that is totally acceptable. So getting into the brain death testing itself. So the most important thing before you're proceeding with brain death testing is you really have to make sure there are 3 big prerequisites met. There are 3 big things that you need to ensure before you ever move forward with testing. So number 1 is that the patient has had some sort of permanent whole brain injury. This is a catastrophic permanent brain injury by an identified mechanism. If it's not clear to you why the patient has an exam that looks consistent with brain death, then it's important to go back to the drawing board and understand that before you proceed. And before proceeding with brain death testing, the neuroimaging needs to be consistent with the mechanism and severity. So let me go through some examples of what I mean by that. So say you have a 32-year-old patient that was found unresponsive. EMS arrived on scene. Like I said, patient was unresponsive. They got patient intubated. Patient never lost a pulse. And all the initial, workup doesn't show any intoxicants or anything like that. But the patient has an exam as such as in a coma, absent brainstem response, no motor response, and is not taking breaths over the ventilator. You do a CAT scan, and this is what you see. If people could enter into the chat, and basically they can what you can do is you could select me, or I'm the presenter, and you could just put your answer so I'll see it if you don't want other people to see your answer. Is this somebody that you would move forward with brain death testing in? So I'll give you a couple seconds to answer put your answers in the chat. Just yes or no. Is this somebody that you're going to move forward with brain death testing in? Their exam is they're in a coma, absent brainstem reflexes, no motor response. All right. So I'm seeing the answers come through. Great job. So, no, right? This is somebody who you have to think about brain death mimics. So the common ones being, is this patient very hypothermic? Could they have some sort of intoxication that's not being tested for on the standard toxin panels at your hospital? For instance, baclofen, a baclofen overdose. Could it be somebody who has botulism? Variant GBS sometimes will create essentially a brain death mimic, or do they have profound metabolic derangement such as profound hyperammonemia that is essentially making them look like they are brain dead? Alternatively, this would be a patient, and sorry, let me go back to that for 1 second. I just want to point out, this is a relatively normal CT. You can see the folds of the brain, right? So there's no sulcal effacement. I'm seeing space in between the gyri here, the sulci. I see relatively good preservation of a gray-white here. So this is not somebody that their CAT scan meets that looks like they've had a catastrophic brain injury. Compare that to this patient. So this is somebody who was also found down, unresponsive, lost pulse in the field, had 10 minutes of CPR, ROSC was obtained, they are admitted to the ICU, you get a CT, and this is very different, right? So you see complete sulcal effacement. I don't see any differentiation between gray and white here. You see complete effacement of the basilar cisterns here. And so this is somebody that, if the next steps are met, you could proceed with brain death testing. Similarly, let's say you have a patient, and I'll ask you to enter your responses in the chat here. So this was a 45-year-old patient who had what seemed like a syncopal event at home, briefly was responsive and then became unresponsive, never lost a pulse, was intubated in the field, never seemed to be hypoxic, but is admitted to the ICU. This is the CT you get. This is at the level of the pons. You see hyperdensity here throughout the pons. It's really extensive, but that's intracranial hemorrhage. And this patient is coma. And it's off sedation, coma, no brainstem response, no motor response. Is this somebody that you're going to move forward with brain death testing in? So if you could just again answer in the chat. Okay, all right. All right, so thank you for responding. So I think the answer is it depends. So we're only seeing a portion of this CT. We're seeing it at the level of the pons. Let's say that we scroll up and towards the apex and we see this. So at the level of the basal ganglia and the thalami here, I see really good gray-white differentiation. I see nice sulcation, right? The sulci aren't completely effaced. And so this patient is somebody who has, yes, they have very likely devastating brainstem injury, but there's preservation of gray-white, there's good sulcal definition. And so this is somebody that is not consistent with whole brain injury. So you have to have injury to the entire brain, not just the brainstem, to move forward with brain death testing. Now, if you scrolled up towards the apex and you saw this, the loss of gray-white, I'm not seeing any sort of sulcation. This would be somebody that, okay, not only have they have a devastating brainstem bleed and by exam, absent brainstem response, but they've also had catastrophic injury to their the cortex and subcortical areas. All right. So we went through the first prerequisite. You have to show on neuroimaging that there's been some sort of catastrophic injury and that the injury makes sense with the way the patient's exam looks. So the number two prerequisite is you have to give the guidelines recommend giving an observation period to just answer the question, is this a permanent injury? Is this temporary, essentially shock of the brainstem, or is this permanent? And so they've made some recommendations that haven't changed. These are no updates to these, but for patients that are less than 24 months of age, they recommend at least a 48-hour observation period, keeping in mind that around 24 months of age, most patients will have their fontanelles closed. Before then, they're not. And so this is giving you a period of time to see how the brain is going to react to whatever injury it's had, keeping in mind that those fontanelles aren't closed. For patients that are 24 months and older, this is including adults, the recommendation is to wait at least 24 hours after a hypoxic ischemic injury. So somebody, this is our cardiac arrest patients who's coming in, they may look clinically consistent with brain death immediately, but we really need to give 24 hours for permanency. And understand, is this just the initial hypoxic result that we're seeing, and there's going to be some recovery of cranial nerves or brainstem response, or is this permanent? The other point is, if you have a patient that you've decompressed, say they had a massive stroke, they got decompressive hemicranie, or a patient that got an EVD, maybe for an intracranial hemorrhage with intraventricular extension, needs to be some amount of observation period that's given to answer the question is, did that intervention work? Did that somehow relieve pressure? And now I'm going to get a response in some of my absent brainstem reflexes. Now, the guidelines do not give a time for that. They say sufficient amount of time, which is not very helpful. But I would say, my general practice is still that 24-hour period. The third thing before proceeding with brain death testing is you really want to exclude any confounders. This is just excluding anything that could be mimicking brain death and perhaps skewing what you're seeing on exam. And so there's a lot of confounders to think about. But the big one is there some sort of intoxicant that is mimicking brain death in this patient? We not uncommonly see patients who have intracranial hemorrhage that may or may not progress to brain death, that maybe they had an overdose as well at the same time. And so you really have to be mindful of that. Now, that's not to say you have to do a tox screen in every single patient. Like if there's no concern for some sort of toxidrome by history, and you have another mechanism like massive intracranial hemorrhage, you would not have to get the tox screen. But I would say, in general, my practice is all of these patients are getting tox screens. So, if indicated, you get the tox screen. You also want to make sure that alcohol isn't on board and potentially confounding your exam. The other big one would be medications. So considering that these patients may have gotten medications by EMS, by an outside hospital, and maybe initially, at your institution, you want to make sure that these medications are not interfering with the exam, the brain death exam, and what you're seeing. And so in general, you're giving 5 half-lives for CNS depressants. The thing to consider is in somebody who maybe has concomitant liver renal dysfunction, is obese, hypothermic, or is older in age, you might have to give longer than 5 half-lives. I'm going to give you a reference that you can refer to for these patients on the next slide. And then if paralytics were given for intubation, then you'll want to exclude that could be confounding the exam as well via a train of 4 before proceeding to brain death testing. For temperature, hypothermia can affect your brainstem response. I see this in my patients that, say, the acute liver patients, that we may be dropping their temperature for cerebral edema. A lot of times they'll lose their pupillary response at around 33, right? So this can certainly affect various responsive responsiveness of the brainstem reflexes. And so the recommendations are that the body temperature should be 36 degrees Celsius and above. It's not really a change in the adult guidelines, but the pediatric guidelines said 35 previously. And so it's a slight change for the pediatric guidelines. The other sort of guidance that it gives you is that if the body temperature got to be 35.5 or less, then you need to wait 24 hours at a temperature of 36 degrees Celsius and above, just to give time for those reflexes to potentially rebound and start functioning properly. Blood pressure, so a slight change here that I'll tell you about. So the prior guidelines said that to ensure that hypoperfusion wasn't contributing to the neurologic exam that you're seeing, that in adults, systolic blood pressure should be greater than 100 millimeters of mercury, and then in children that it should be it shouldn't fall below 2 standard deviations of normal. So they've altered the wording slightly in that for adults now they've added that MAP goal as well. So systolic should be greater than 100, MAP should be greater than 75 millimeters of mercury. And for children, the systolic and MAP should be greater than or equal to the 5th percentile for that patient's age. And then the final confounder you would want to exclude would be some sort of severe metabolic, this could be liver, renal dysfunction, acid-base dysfunction, and endocrine confounders. So the example would be, you have a patient that has acute renal failure and their, BUN is 100 and they're not making urine, and this is somebody that, you cannot say that this metabolic confounder is not affecting the exam that you're seeing. So in these patients, when possible, you want to correct any of these possible confounders, whether that's allowing sufficient time for medications to be cleared out of their system, increasing their body temperature, normalizing their blood pressure to these targets that would not lead to hypoperfusion and dysfunction of the brainstem, and also correcting metabolic derangements that you're able to. So I wanted to provide you guys with some QR codes. The one on the bottom here I find really, really helpful. So this QR code will link you to a table that the AAN has put out in conjunction with Neurocritical Care Society for the accepted metabolic values to proceed with brain death testing. Basically, values within the ranges they give should not be expected to affect your brain death test, your neurologic exam. And so I find that very helpful to refer to for the patients that I'm seeing. And then they have this great table that provides the common medications, the common ones we see, obviously, like all of our sedative drips, and various other medications, and their half-lives. They also provide some guidance about, for patients that are obese, hepatic insufficiency, renal insufficiency, and potential, waiting period for those patients who may not be metabolizing and clearing medications as would be expected. The other QR code here is the Brain Death Toolkit, which is very, very helpful. You do have to this is through the Neurocritical Care Society, you have to create an account, but it should be open access after you create the account, and you would be able to, pull up these tables. You can refer to the guidelines here. You can, there's multiple other different neat things on there. So I would encourage you to check those out. All right. So once you've answered all your prerequisites, this patient has some sort of catastrophic brain, the neuroimaging looks like this is something that would lead to brain death. I know that I've observed for permanency, this is not a reversible thing, this is permanent. And 3, I've ruled out that there are any confounders that could be contributing to the way this patient is looking. At this point, you can proceed to brain death testing. A brief intermission, I will say before proceeding, It's really important to communicate with the patient's family or loved ones or whoever is there with the patient about this process. The fact that, you know, you are concerned that they've had some permanent irreversible injury to their entire brain. Communicating that early on and giving them anticipatory guidance is really, really helpful. I would say that the one thing that is I think becoming increasingly clear is that family or loved one present for the brain death testing is actually very helpful. So this has been studied, and patients, families who are able to be present for brain death testing have such a better understanding of what's going on. We've not demonstrated that this necessarily improves well-being in the long run. I mean, they're clearly still losing somebody that they care about, but it has vastly improved understanding of what's going on and provided some, you know, support that way. So I think that's very helpful. The other thing I would say is talking to patients' families early about the testing that you're going to do. You know, tell them about the brain death exam, and also counsel them early about spinal reflexes that, you know, can be really distressing for families to see. You know, even if it's just triple flexion in the lower extremities, they think, oh no, oh, they're moving, they responded to something you're doing. And so counseling them early about how that is not a signal from the brain, that's actually a very concerning thing and could be consistent with brain death is really important, and I think will save you a lot of time after the testing trying to explain that to them. So once you've counseled the family, you can move forward with the brain death examination. Before we get into what that entails, there's some important things to think about in terms of the number of exams that you have to do. For adults, patients 18 and older, you have to do at least one exam. Now, the guidelines have changed the wording a little bit in that they've put a slight preference on 2 exams and that it may decrease your risk of false positive results, but it's not saying you have to do 2 exams. It's just saying it might decrease the risk of false positive results. So I would refer to your local institutions. The one hospital I work at has to be 2 exams. The other hospital is just 1. So make sure you're following your hospital policy. Now, 1 apnea test is still okay, even if you opt to do 2 neurologic exams. 1 apnea test is still okay per the guidelines. For children, there's no changes here. The recommendation is that 2 clinicians perform separate exams, each with apnea testing, with a minimum of a 12-hour observation period between each test. And the big thing is you can never bypass the brain death exam with ancillary testing. We're going to talk later about the indications for ancillary testing. Ancillary testing is not needed in most cases for declaration of brain death, but you can't use it in lieu of doing the testing. And unfortunately, I think that that's a thing that is done sometimes, and that is not consistent with best practices or what the guidelines say. The final thing is, all parts of this brain death exam that we'll go over, the neurologic exam as well as the apnea, all parts that can be done should be done before proceeding with any other testing. Should never omit any parts. So for the neurologic exam, I'm going to keep this part brief. There's no changes here to this. I did want to include a little QR code to a great brain death video that was put out by AAN, and it's pretty good. So if you want to refer to that, by all means do. There's the QR code for it. But essentially, in the neurologic exam, you want to demonstrate that the patient is comatose. There's no response to visual, auditory, tactile stimuli. You are demonstrating there's no motor response. Now, you may see spinal reflexes, and we'll get into some of those later, but there's no motor response coming from the brain. You want to demonstrate absence of brainstem reflexes. So, you know, checking for pupillary response, checking for corneal response, checking for oculocephalic reflex if the patient has a stable C-spine, doing cold calorics or checking for ocular vestibular responses with cold caloric testing, checking for a cough, a gag. So you're looking for absence of all of those brainstem reflexes. I'm also going to link a QR code here, and you can get to it through this toolkit, but just in case you can't access that toolkit, I also wanted to just provide the table to you. The AAN and NCS has put out this wonderful table with all components on the of the exam, and they, provide, descriptions, how you should be doing the test, great little pearls for the test. It's always nice to refer to those and just sort of, remind yourself before you're doing this test. If you're not doing these tests a lot, but you are credentialed to do them, then that is a nice table to refer to. So if any part of this neuro exam is not consistent with brain death, you cannot proceed, do not proceed to apnea test. That will just be confusing for the family and the loved ones, that the test at this point is not consistent with brain death. And so if this is the case that you're in, what we would do is give another observation period, waiting. The guidelines do not, comment on this, but potentially waiting 24 hours. And if the exam is still consistent with brain death, proceed again. So restart, complete the neurologic exam again. Again, if there are any sort of response that is mediated from the brain, meaning any brainstem reflex, any motor response that is not spinally mediated, or response to the visual, auditory, and tactile stimuli that is not spinally, that is not mediated by the brain, that would be somebody that does not fall into the brain death criteria, and you should not proceed. All right, so if you do the neuro exam and the patient is comatose, no brainstem response, no motor response that's mediated from the brain itself, then you can proceed with apnea testing. And so again, just to refresh the memories here. So for adults, you only have to do one apnea test, even if there's 2 exams done, or if that's a requirement by your institution. For a child, there are 2 apnea tests done after each neuro exam. And remember that between exams, they do a 12-hour waiting period for children. So for the apnea test, I'll spend a little bit more time talking about apnea, even though when you boil it down, there's not too much that's changed in the guidelines. They did provide some more specifics that I want to make you guys aware of. But essentially, the guideline has always been that you want to make sure that a patient is stable enough to tolerate apnea testing. When you're doing the apnea testing, obviously, the patient is not ventilating. The CO2 is going to rise, the pH is going to rise, and in somebody who has an intact respiratory center in the medulla, that will trigger a breath. And so what you're functionally doing is making sure the CO2, the pH is changing enough that it's stimulating the chemoreceptors in the medulla. And so that could be quite stressful on somebody's body, right? That acidosis could lead to hemodynamic compromise, hypotension, and certainly patients could have a cardiac arrest during apnea testing. And so you really want to make sure with these prerequisites that it's safe to proceed to apnea testing. Because if the patient isn't stable enough for apnea testing, at that point you could get ancillary testing. So the prerequisites here, just like we talked about for the brain death evaluation in general, you want to make sure your blood pressure targets are being met. And remember, there was the slight change in that they've now added a MAP greater than 75. You want to make sure the patient's euvolemic. This will help ensure that they're not going to develop hypotension with their acidosis that's going to come about. And then you'll want to make sure that the patient is essentially normal from a blood gas standpoint before starting. So the patient has a normal pH, the PaCO2 is 35 to 45. The slight, addition that I'll talk about on the next slide is in this guideline, they talk about CO2 retainers, where that was not really discussed in prior guidelines. And so essentially what is said is in patients that are CO2 retainers, if that baseline CO2 is known, that should be your starting CO2. So it wouldn't be this normal range, it would be whatever that patient's normal CO2 is. If a patient is a suspected CO2 retainer, but you don't know their baseline, that's somebody that's going to need apnea testing just to because with apnea testing and you don't know that patient's baseline, maybe they're used to living at a pH of, or sorry, at a CO2 of around 60. And so even if you're allowing the CO2 to climb up, maybe that's not going to stimulate their chemoreceptors in the medulla. So the other thing is you'll want to make sure that the patient is pre-oxygenated with FiO2 of 100% for 10 minutes, and that ideally you've got a PaO2 of greater than 200. That would suggest that they're going to be able to tolerate the apnea exam from a respiratory standpoint. The other thing is the guidelines say that they don't say you must have an arterial line present, but they say you should have an arterial line present. And I think that it is important because, you know, we not uncommonly see patients become hemodynamically unstable during the test. And so it's helpful to, you can totally titrate your pressors that you have at bedside so the patient can tolerate the duration of the apnea test. If you're only checking by a cuff, it's going to be a lot more difficult to titrate, and that person could have hemodynamic collapse while you're doing the apnea testing. The other thing is when we're doing the ABGs, you'll want to make sure you have a quick, reliable way to get arterial blood so you can do ABG testing. Now, once those prerequisites are met, you can move forward with apnea testing. I would say I have my little pearls up here in the right upper corner of the screen, but essentially you want to make sure that your respiratory therapist and the nurses in the room, you know, they're incredibly helpful in these situations. And I do not do brain duct testing without them. There for the entirety of the exam. The respiratory therapist is vital in, at least at our institutions, for, you know, ensuring that the patient is disconnected from the ventilator, if that's the mode that you do for apnea testing. That also bring their equipment for like iStat for running rapid ABGs. And then the bedside nurse is incredibly helpful for titrating your pressors to make sure that you're still meeting your systolic and your MAP goals. And so I think that that is a must, although it's not commented on in the guidelines. So throughout the test, you have to meet your blood pressure targets, like we previously discussed. And I think that what is helpful and not mentioned in the guidelines is giving yourself a blood pressure buffer. So if you're starting this test and somebody's MAP is 76, 77, you know, certainly there are people that you stop ventilating and just oxygenate and their blood pressure rises. But what happens a lot of the time is, you know, with worsening acidosis, the blood pressure actually drops and the patient can become hypotensive. And so what I find is helpful is just to go ahead and have levo hanging if they're not already on levo. And, you know, even starting at levo 5 micrograms and in saying, okay, I'm going to get the MAP up to 85 before I even start the test. And not going to harm things at this point, but it's just going to give you more of a buffer to get through the apnea test. So have the levo hanging and ready to go at the very least. Again, not mentioned in the guidelines other than these blood pressure parameters, but just some tools that I find helpful. So for the apnea test, again, you're going to get that baseline ABG to make sure your prerequisite targets are met. You want to make sure you're starting with a normal pH, normal CO2, and make sure that your ideally your PaO2 is greater than 200. This is somebody that's going to tolerate the apneic part of the test. And then you're going to be providing oxygen without ventilation. So for the apnea test, the way that we most commonly do this in adults is disconnecting the patient from the ventilator, and you're providing 100% O2 with a catheter that's stuck down into the ET tube lumen to the level of the carina at a flow rate of 4 to 6 liters per minute. I bolded the 4 to 6 liters per minute because I certainly have seen people do a higher flow rate, 8 to 10 liters or something like that, and that can be a catastrophic situation. You can have so much flow going into the lungs that you actually overinflate the lungs, decrease your preload, and somebody can actually have a cardiac arrest in that scenario. So you want to make sure that the flow is not over 6 liters. I've seen that. So I'd be very, very mindful of that. The other thing is you want to make sure that the catheter that's going into the ET tube is less than 70% diameter of the ET tube itself. So this is really only an issue for, like, patients that have really, really small ET tubes or like pediatrics, right? Because even if you're putting 4 to 6 liters a minute of flow through this cannula, it has no way to escape. And so that's another instance where you can have overdistension of the lung. In those scenarios, there's reports of pneumothorax, cardiac arrest during the test. So you really want to be mindful of that. The other modes you can use, you can stop intermittent mandatory ventilation if your ventilator will allow for that, and just deliver 100% O2 through the CPAP on the ventilator without the intermittent ventilation part of it. You can disconnect from the ventilator and provide 100% O2 through a inflating resuscitation bag with a PEEP valve. And so same for children. You could do either one of these 2 options, and generally the top option is not selected just because the cannula and the ET tube sizing creates a dangerous situation. So once you're doing this, you're observing the patient for 8 to 10 minutes, or what the guidelines say, before restarting ventilation. And the reason for this is, the PaCO2 rises about 2 to 3 millimeters per mercury per minute. So you're really wanting the CO2 to rise enough to be an appropriate stimulus to the medulla to trigger a breath. So you're observing the patient. I always uncover the patient and I warn the families. I say, I'm gonna take off their gown, expose their chest, and I'm going to be really focused on looking for any sort of breathing. I'll usually also warn families during this time that sometimes you can see really strong heartbeats that sometimes will trick your eyes and you think, is that a breath? But it's really the heart beating in the chest, and that can actually be really strong and really apparent. So sometimes I will warn families about that, especially in somebody who's thin or young and going to have potentially easy to see cardiac movements through the chest. So you're watching the patient's chest for that full observation period. And then, in general, sending at an ABG at 10 minutes, you can wait for a longer period and send an ABG after 10 minutes. I used to do like 8, 10, and 12 minutes, but I just found that was too many moving parts. It was just a lot going on. So generally just send the ABG at 10 minutes. That should give enough time for the CO2 to reach the appropriate level. So the test is consistent with brain death if the patient doesn't take any breaths, if the PaCO2 is greater than or equal to 60, and the change in the CO2 from the baseline is more than or equal to 20 millimeters of mercury, and the pH is less than 7.3. So the change in the guidelines is just that it used to say that these were an or, like the CO2 needed to be more than 60 or greater than 20 from the baseline. And so they've changed that to an and, just to ensure that there's an appropriate trigger for the medulla. And then they've added the pH requirement because they also, are mindful of, we have, for the chemoreceptors to respond, and for the most sensitive way to really test this, we need to ensure that our pH is low enough to stimulate the chemoreceptors. The guideline writers also put in some guidance for patients that are CO2 retainers, which is really helpful because, you know, previously we're sort of left with, well, I know that they're a CO2 retainer, they have COPD, and, you know, when they came in, they had a normal pH, but their CO2 was, you know, 50, and they're on home oxygen, and, well, I guess we're just going to have to get an ancillary test in that patient. But now we have guidance for these patients. So if we know their CO2 at baseline, then for these patients, we would start with a CO2 at whatever their baseline is. If it's 50, you start with a baseline CO2 at 50, but you would need your after apnea test for your ABG to show that the PaCO2 had come up above at least 60 and above 20 points above whatever the baseline was. If you suspect that the patient is a retainer but you don't know the baseline, then that patient would need ancillary testing, because you can't say for sure that you've provided enough CO2 stimulus to make the respiratory centers of the brain respond. So for the brain death testing and apnea tests, you know, this is the highest risk part where people can become unstable. And so it is okay to abort the testing if the patient becomes unstable. It's kind of traumatic for families if the heart stops during the apnea testing. And so, you know, it's okay to abort the exam. So the things that would make you abort the exam and the recommendations are that if the patient has an arrhythmia and they become hemodynamically unstable with that arrhythmia, that would be a reason to abort the exam. If they become hypotensive and you're unable to correct that with fluids and pressor titration at bedside, you would abort the exam. And if their SATs, their O2, peripheral O2 SATs are dropping below 85, you would want to abort the exam. The new information about apnea testing is the guidance that the guideline writers gave surrounding VA ECMO. So previously, you know, patients on VA ECMO were, you know, could proceed with brain death testing if they seemed to meet all the prerequisites. But there wasn't really a lot of guidance in the literature. And so they wanted, and it wasn't mentioned on prior guidelines. So essentially they provided that information. The sort of concept here is that for patients on VA ECMO, you know, the barrier here is that our overarching goal is we're trying not to we're trying to get the CO2 high enough in the patient's system that it triggers the medulla to take a breath, right? And so for patients on VA ECMO, the membrane lung, you can clear out CO2 that way. And so you get into the situation of you can't get the CO2 high enough to stimulate the medulla. And so they wanted to provide some guidance for this. The other issue is that in patients that have intrinsic or native heart-lung function, you can actually have essentially that returned blood that's coming back in mixing with blood that's coming from the native heart and lung, and that is another reason why you might not get high enough CO2 levels to trigger any sort of breath from the medulla. So essentially, they provide guidance on that. And briefly, you know, in general, you still want to maintain a MAP greater than 75 in these patients to ensure that hypoperfusion is not contributing to the reason why they're not taking a breath. You're pre-oxygenating just like you were before, but you have the addition of pre-oxygenating with the membrane as well. And essentially, to get around the problem of CO2 being removed from the membrane and not rising appropriately, you can actually titrate exogenous CO2 into the ECMO circuit, or you can adjust the sweep gas flow rate to 0.2 to 1 liter per minute to ensure that the CO2 is rising enough in the system. And then just to make extra sure that your CO2 and your pH is an appropriate level to say apnea testing was confirmatory of brain death, you would want to sample from both the ECMO post-oxygenator and the arterial line, the distal arterial, whatever distal arterial line you have, you know, usually a radial line, just to make sure that you've for sure met those criteria that the patient has gotten acidotic enough and the CO2 has risen high enough to stimulate the medulla. So if all parts of the neuroexam and apnea can be completed and all the findings are consistent with brain death, this is brain death. This is death by neurologic criteria. No further testing is needed. The patient is dead. This is unchanged. This is exactly what the guideline said before. There's no changes there. So a lot of people ask, but when do I need ancillary testing? And there's a lot of confusion around this, and it makes sense why. I mean, this is, kind of it can be a confusing topic. So when do patients need ancillary testing? There are 4 primary reasons. So just keeping it simple, the first one is fractures and facial injuries, just an easy memory trick. But essentially the details of that are, if somebody has some sort of high cervical spine injury, like shown in this MRI here on the left, with spinal cord compression, that may be somebody who cannot generate a breath even with apnea testing, even if they're not brain dead. And so in that patient, you would want to get ancillary testing. If the patient has facial injuries, for example, orbital fractures, skull base fractures, something that's going to, maybe that the fracture and the injury to the nerve is what is creating this exam that we're seeing, and not the injury to the brain itself. And so for those sorts of patients, you would also want to get ancillary testing. The other thing to consider is in somebody who has really terrible scleral edema. We've all seen these patients where like their sclera is like popping, bulging out through their eyes, and their iris and pupil are like depressed inward, and you can just see all the sclera. That's somebody, when you're doing the oculocephalic testing, when you're doing the oculovestibular testing, there's so much edema that you can't say that maybe the edema is preventing the movements of the eyes and not the brainstem permanent injury. And so for those patients, that would be somebody that would need ancillary testing in addition to what you've already done. You would never bypass the neuroexam and say, well, this patient doesn't have an eye, or they were enucleated for some reason, or they had orbital trauma as a kid and their pupil doesn't react, so I'm just going to get ancillary testing. You would still do all parts of the exam that you can. You would just add on ancillary testing. So the second reason would be maybe you can't perform or complete the apnea testing. So for example, maybe your patient is on, almost max dose Levophed, they're on vaso, and you have no room to titrate if they were to become unstable during apnea. That is somebody that I'm going to get ancillary testing on, because I don't think their hemodynamics are favorable and I don't want them arresting during the apnea test. The other example, somebody who has, maybe they have concomitant ARDS, they're on high vent settings, there's no way that they're going to tolerate apnea testing, right? Maybe they're like PEEPs 12, FiO2 60%, even with pre-oxygenation, their PaO2s 100. That's somebody that probably is not going to tolerate apnea testing. And so, or maybe you try to do the apnea testing, and like is shown here on the right, the patient develops a MAP of 49 that's not, you can't, titrate pressors, it's still not recovering, so you abort the apnea testing. That's somebody that you could then do ancillary testing on. The third reason would be for during the neurologic exam, say you're seeing some sort of movements that you're not sure if they're spinally mediated or not. I'm not talking about the classic triple flexion response. We know that's spinally mediated. Like, that's not somebody I'm getting ancillary testing. But there are some really, really impressive spinally mediated reflexes that we can see, like flexion of the trunk, head movements, thumbs moving like this. And so in those patients, I would say, no shame in your game. It's okay if you get ancillary testing in those patients, right? This is a diagnosis that we can't get wrong. But just to hammer home the point, if the movement is clearly a spinal reflex, you do not need ancillary testing. This is just in the event where you're not sure, and maybe a more senior person doesn't know, or one of your colleagues isn't sure either. The fourth reason to get ancillary testing would be if there are metabolic derangements that cannot be corrected. Not talking about somebody necessarily with renal failure that you have them on CRT and you're correcting the derangements before you do testing. I'm not talking about that scenario, but this would be somebody with shock liver, perhaps hyperammonemia that's not recovering, and you're not going to be able to correct it to normal, and that could confound your exam. So again, I just want to hammer home the point that just because one of the prerequisites aren't met, namely like any of those metabolic temperature confounders, you can't bypass those with ancillary testing. You can't just say, well, the patient was 33, so we're just going to do ancillary testing. You have to correct all of those prerequisites that you can reasonably correct, and you should not use ancillary testing to bypass those things. So there's 3 accepted ancillary studies for adults, 2 for children. There's been a slight change in the guidelines. The old guidelines for the adult said that EEG could be used for ancillary testing. That can no longer be used. That makes sense. You know, with brain death testing, we're trying to show that the whole brain is permanently injured, and there's no coming back from that, right? EEG is only looking at the cortex. It's not telling us about brainstem function. So EEG was taken out. So the 3 accepted studies are 4-vessel cerebroangiogram. So this would be an example on the left of a patient. You can see their ICA here. There's good intracranial flow. That's not consistent with brain death. This patient here on the right, that you can see the contrast coming up into the ICA, and you don't see any intracranial flow. That's somebody who would be consistent with brain death if the other parts of the brain death testing were consistent as well. Transcranial Doppler, it's not been validated for use in brain death testing in children, but in adults you can use transcranial Doppler. And then this would be a pattern of that would be consistent with brain death. You see that there's systolic flow, but during diastole you have reversal of flow, so this is called oscillating or reverberating flow. And if you saw that in all the vessels incinerated, that would be consistent with brain death. You know, in terms of which one to get between these 2, I would say that getting a diagnostic angiogram is, one, it's invasive. The patient has to travel. You have to find a neurointerventionalist that's going to do it. So in most shops, like we're not doing that. That's a lot to do. So this would be a test that if it's offered at your institution, it's sort of like my go-to ancillary test because it can be done at the bedside. The patient doesn't have to travel. The thing to know is about 10 to 20% of people might have too thick of temporal bones, and so you can't incinate the anterior vessels. And so, you know, it might not be appropriate for all patients. And then the third test would be a nuclear medicine test, and this could be used in adults or pediatrics, but essentially you're looking for radiotracer uptake in the brain, and what's shown here, you see there's no uptake in the brain. Compare that to, you can see the tops of the lungs here where you have the tracer uptake in the lungs. You can also see this sort of hot nose sign where there's uptake in the nose here. And so that's, in somebody who's not brain dead, the brain should look like that as well. But you see this hollow skull sign. So some final special considerations that were commented on just very briefly is that, you know, consent is not required to do brain death testing. You know, certainly refer to your hospital policies and any state laws. But in general, this is a state where you're worried about death. You wouldn't ask for consent to do declare somebody dead by cardiopulmonary criteria. And so consent is not required. Obviously, communication with family is certainly so important. And so, of course, you're talking with families. The other special consideration that is brought up in these guidelines that's not in the prior guidelines is neuroendocrine function. So what I'm talking about when I say neuroendocrine function is basically the presence of or absence of diabetes insipidus. And so for these patients that progress to brain death, some of them will develop diabetes insipidus. And so there's often a debate about, do you have to have that to be consistent with brain death? And the guidelines now comment on that. And basically the thing to know is that you can have variable extracranial vascular supply to your hypothalamus and your pituitary axis. And so although you can have whole brain permanent catastrophic death of cortex, brainstem, and all the spaces in between, because of that extracranial vascular supply in some people, you may not have progression to DI. So the guidelines actually say that just because somebody is not in diabetes insipidus does not mean you can't move forward with testing, and people can have neuroendocrine function that are, brain dead. We talked about the primary posterior fossa injury, but I just wanted to point out the guidelines comment on it now. They hadn't commented on it before, but it's basically saying patients with injury into their posterior fossa, namely the brainstem, can look clinically consistent with brain death, but you have to make sure that their imaging also shows that supratentorial injury like we talked about before. The guidelines also discuss pregnant patients and basically say that pregnancy is not a contraindication to brain death determination. It is, you can proceed with brain death testing in this patient. Once they are determined to be dead by neurologic criteria or brain dead, you really want to have a very multidisciplinary approach to talking to those the surrogate decision makers. So the family, the next of kin, who are going to be making the decision to continue organ support, and that's going to involve people like OBGYN, high risk, MFM, ethics, legal, the ICU team. It's going to be a very multidisciplinary approach to offering support for that family about what to do about continuing organ support for the viable fetus. And with laws changing surrounding these very delicate topics, I would just say there's no shame in referring to your state laws, seeking legal counsel from legal and ethics in these very delicate situations. Finally, the guidelines have offered some information about the time of death, because there were some questions about that. But essentially, the time of death is the time of the ABG result at the end of apnea testing. Or if the patient had ancillary testing, the time the attending clinician reported that out, the timestamp in the ancillary study. And then they broached the topic of, when do we turn off organ support, right? Because after apnea test is done, the patient is placed back on the ventilator, organ support is continued while the family is being counseled and dealing with this declaration of death. And so that can create a lot of issues about when organ support is stopped. And so essentially the organ support can be continued as deemed appropriate by the attending and hospital policy. So for example, at Grady, we say up to 24 hours unless there's some sort of extenuating circumstance. And it's really important to let families know that right away, as you're counseling through the testing. So some other pearls are just, I think, when you're talking to families before brain death testing is done, I think it's helpful to avoid saying things like, well, they're essentially brain dead, or they seem like they're brain dead, before the declaration is not made. You could say things like, I'm concerned that there's been a permanent injury to the brain, and we need to do testing for brain death, or something like that. But it can create a lot of confusion for families who hear the words brain death and they think, oh, they're brain dead, and then they don't understand why we're doing testing or something like that. And then always just refer to your local policies. There's variations at different hospitals, and so while the guidelines are very helpful, would default to your local policies. What if you don't do brain death testing and you consult for it? Well, I would say that the AAN has a great brain death evaluation tool. to make sure all the prerequisites are met and this person qualifies to start brain death testing. So here's a link, a QR code for that. And basically it will just help you walk through, like, is this patient appropriate to proceed to brain death testing? And you could use it as you're thinking about, consulting for that testing, just to make sure that everything is teed up and appropriate to move forward. So really the take-home points here are that the new things are that the guidelines are now combined between adults and pediatrics. There was some tweaks to the specifics of apnea testing, and they added some special considerations for ECMO patients, pregnant patients, and patients with infrantorial injury. But in general, the basics of brain death testing have not changed. You always want to make sure that a patient meets the prerequisites to proceed with testing. We talked about that, and that's that they have a catastrophic brain injury that explains their exam, and neuroimaging is consistent. You've given the time and observation period, and you've excluded confounders. Again, you complete the neurologic exam and apnea test as we talked about from the guideline, and you only do ancillary testing if there's some part of the exam you can't complete, but you can never use it, or you should not be using ancillary testing to trump or bypass correcting confounders. Remember, family focus and family support is super important, and really needs to be it's probably one of the most important parts of brain death testing, is providing that support and explaining things to family. Having them be present for the brain death testing is an evidence-backed approach, and then refer to your local policies. So I'll leave you with this. Here is a QR code to this toolkit again, with all of these tools, so you don't have to remember anything I said. And then you can always email me if you have any questions about anything, or if you have trouble accessing any of these, I'll send you a PDF. I'm happy to do that. All right, and I'll take any questions.
Yeah, thank you so much, Dr. Sigman, for the educational talk. I especially enjoyed the QR codes that you posted for any resources for our audience to go back later. Just a reminder that this will be posted on our YouTube channel later on. At this time, if you have any questions, feel free to raise your hand virtually and I can unmute you, or you can utilize the chat box. And if you do utilize the chat box, please send chat to all audience or organizers and panelists so I can read them. Thank you so much. And while we're waiting for any questions to come over, I do have one question for you, Dr. Sigman. So at an institution that doesn't currently have the brain death exam evaluation policy or procedure established, what is the biggest challenge that you foresee in implementing a policy that's standard and working for the institution?
Ooh, yeah, that's a great question. So one thing that I think is super helpful is, obviously, if there's a group of intensivists, pharmacists, like having a very multidisciplinary approach to this, like, if you have a neurologist, great, have them on, some sort of working group, a group of people that are interested in this. And we have representation from, like, our SICU team, neurosurgery, MICU, like all of the various ICUs, as well as neurologists, neurointensivists, pharmacists. So have a very multidisciplinary panel that's all interested in this topic. And then I think one thing that's super helpful is in this brain death toolkit. And again, if you can't access the toolkit, I will email you any of these things, no problem. But they actually have a sample brain death policy for hospital adaptation. So I think that can be the hardest thing, is like, how do I distill these 85 guidelines into a policy that is not entirely confusing and like will make sense? And so I think that that's probably the biggest barrier, but I think it's very helpful that they provide a sample policy. So it's, getting a group of people together that is aware of the guidelines, have read the guidelines, comfortable with brain death testing, and then creating the policy, I think, is the biggest barrier.
Thank you so much.
Yeah.
And I don't have any other questions that I can see from my end. Was there any question directed to you specifically in your chat box?
Not that I see.
Okay. All right. Well, if there's no more questions, we'll conclude the meeting at this time. If you think of any questions later on, feel free to send us an email at communications@sccmsc.org, or you're welcome to email Dr. Sigman on the slide. Well, thank you so much, Dr. Sigman, for your insightful talk and your contributions to critical care.
Yeah, thank you again for having me. I really enjoyed it. And again, please don't hesitate to email me. This is strangely a very interesting topic to me, and I enjoy helping people with this topic. So, all right, thank you.
Thank you. See you, everybody.